Right, recording has now started for the second and last part of our Mod 3 review session, right? So this is now going to cover Chapter 14 and Chapter 15 of your textbook. So like I said, before I start the assessment chapters, I'm going to go ahead and send you the overview first. And this is, once again, available in your emails. So it's a rough draft. I'll make it a lot prettier for those of you that need a prettier version of it. So I'm going to start a share screen once again just to go over the secondary, secondary assessment. Okay, so let me just full screen this. Boom. All right. Sorry. Right. So secondary assessment starts with your secondary assessment will depend on whether or not your patient is a medical patient or a trauma patient. Oh, before I begin, can somebody at least in the audio let me know if you're seeing this right now?
Good to go.
Okay, perfect. Thank you. All right, so secondary assessment of a medical patient. Well, first off, it's important for you to determine, is this patient medical or is this trauma? HM1, how will I know that? How will I know that in the test? Well, you will be given a scenario and it will be pretty obvious if it's a MOI or NOI. Even in skills, they're going to tell you, hey, this is your medical assessment. So the clues are being given to you already. In the field, it's probably going to be harder, right? But testing, NREMT, mod tests, and skills, everything is going to be blatantly put in or written down on the test, right? So first of all, secondary assessment medical patient. I have to determine whether they're responsive or are they unresponsive. Because the way I'm going to approach this scenario, again, we're already done with scene size up in primary assessment. We're now entering the secondary assessment. So this is a continuation right after primary assessment is done. So let's first go off with the responsive patients, the ones on the left-hand side. First, I'm going to start with, if my patient is responsive and talking to me, I'm going to start with the HPI. What is the HPI? History of present illness. I want to know what's going on with you right now. How do you do that? Well, you do that by your OPQRST. What's the onset? What were you doing when this began? P stands for provocation. Is there anything that makes this better or worse? Is there anything that provokes this? Q stands for quality. Can you describe the pain for me? What does the pain feel like? R, radiation or region. Where's the pain and does it spread anywhere else? Does it radiate anywhere else? S stands for severity. On a scale of 1 to 10, how bad is your pain? 10 being the worst. And T, time. When did this start? Because remember, onset is what were you doing when this started? T, time, is what time did this start? A lot of students confuse onset and time majority of the times. Okay, so onset, provocation, quality, region or radiation, severity, and time. Then after I investigated about the history of present illness, now it's time for me to identify the past. What's important things that happened in the past medical history. And I'm going to use the acronym SAMPLE. HM1 on your slide right now, it just says SAMPLE. Well, the reason behind that, the signs and symptoms were already verified using your OPQRST. So there's really no need to redo the signs and symptoms of your patient because they just described that to you using your OPQRST. So it won't hurt to tell if you're doing it's like, oh, I'm going to ask my patient again about their signs and symptoms. But it's basically signs and symptoms of the sample is exactly the same thing as the OPQRST. Okay. And then you have the A of ample, allergies. Are you allergic to anything? What are you allergic to, if so? Medication, M. What are your medications are you taking, or are you currently taking any medications right now that I need to know of? P, pertinent past medical history. Okay. Has this happened to you before? Have you been hospitalized over the past 12 months, or is there anything that I need to know of that can help you, so I can help you out with your condition? L is the last oral intake. What was the last thing that you ate and drank and how long ago? E, events leading up to. This is almost the same as onset, but you're still required to ask it. So just to clarify, is there anything that out of the normal that you were doing when all this happened? So that's your PMH or past medical history. Then you have your FPE. HM1, what's FPE? FPE stands for focused physical exam. If your patient is responding to you and they tell you, my chest is hurting based on your radiation on your on your OPQRST, obviously you're just going to do a focused physical exam on those body parts that your patient is complaining about. That's why it's called focused physical exam. And we'll briefly talk about the different types of exams. We're not gonna harp too much on those. So I know some of you are probably like, oh my gosh, I need to memorize all these examinations. Not just quite yet, because when we go to Mod 4, we will break down system by system by system and how to assess that. But that's your focused physical exam right after you get your past medical history. And then you're going to get your baseline vital signs, okay? BVS, baseline vital signs, your pulse, your respiration, your skin CTC, your eyes, and your blood pressure. Those are all the things that goes on your responsive, okay? And then you have your unresponsive patient, okay? So your unresponsive patient, it's just going to do a little flip. So we're going to, since we don't know what happened to the patient, we're going to do what we call an RPE, or a rapid physical exam. The rapid physical exam is exactly the same thing as a rapid trauma assessment, okay? It's just the titles that are different. You're quickly assessing your patient of what's possibly going on. Then you're going to get a baseline vital signs, and then you're going to do an HPI, history of present illness, by asking a possible bystander, hey, do you know what happened? How long ago this happened? And then a past medical history if you can get one, okay? And as you notice on the unresponsive, there's a DPE on there. DPE stands for detailed physical exam if you have time en route, okay? If you have time en route. And repeat that again, detailed physical exam is only going to be done en route once your primary assessment has been taken care of and all life-threatening injuries has been addressed, okay? So that's why it's like in small letters, and it's like at the very bottom of it, only if you do have time for it. But this is basically a quick overview of your secondary assessment of a medical assessment patient. If you look at it too, look at the RPE and the BVS right here. It's almost like a crisscross of happen. This focused physical exam and baseline vital signs switch over there to the RPE and the BVS. And then your HPI and PMH switch down here on the unresponsive side of your patient. So that's the quick overview of secondary assessment of a medical patient. I'm going to stop the screen share right now to entertain possible questions. Right? Any questions with that, class? Somebody's mic is not muted, so I'm just going to call out individuals that are not muted. He, Juan, right. Those that are on the cell phones, please look at your phones as well. Herb, Strong, 954-317-571-256. Okay. Williams, you're asking, what about field impression? The field impression, we're going to talk about that here short. We're going to talk about field impression later on when we're after we've done our secondary assessment of our patient. Okay, so the field impression, that's part of after you've done your secondary assessment, then that's when you're going to come up with, hey, what do you think's going on with your patient? Is this an allergic reaction? Right? So the field impression, it has nothing to do with the secondary assessment. Okay. You have a question, placement. I don't get what you're asking about placement. I don't know what you're referring to when you say placement. Okay.
HM1?
Yes.
You said the detailed physical exam comes after, if there's time during transport?
If you do have time, you're going to consider your detailed physical exam, preferably en route. If you look at on your textbook, the detailed physical exam is only considered if you do have time for it. Once you do, or when you're en route to the hospital after all interventions has been taken care of. Okay, because sometimes when you're still on the scene, okay, a detailed physical exam takes forever. So I want to do that when I'm en route already and transporting my patient. Does that answer your question?
Yes, it does. Thank you.
Okay. like I said, Williams filled. Okay, so I answered it already. Good to go. All right, so that's for your medical assessment. So let's go over that real quick on your chapter 14. So the history of present illness, like I said, that's your HPI, and PMH is your past medical history. We have the acronyms on here on page 336, sample. I already gave you an example of how to ask those questions. It is important for you to know what the abbreviation stands for, the sample and the OPQRST, and how to ask those questions. If you don't know it, then you're probably going to miss a couple of things on our skills, and on our test and NREMT. These are basic things that you need to know how to ask properly, sample, as well as OPQRST. I'm going to tell you right now, OPQRST is where y'all have problems with, because you mix up letters, you forget what they stand for, you forget how they're asked. So please glance over those one last time tonight as well, okay? So OPQRST, onset, provocation, quality, region, relief or radiation, severity, and time. Okay, so that's your OPQRST. On page 338, we examine our patient using observe. So we look, we auscultate, we listen, or we palpate. We use our fingers, the sense of touch. The body examinations from page 335 all the way up to 350, right? So all those, all right, I don't want you guys to freak out over that. I would just, we're going to learn that in mod 4 little by little, okay? But it just basically tells you, for example, if I'm complaining of problems breathing, you obviously know that that is a respiratory system issue. So your book gives you examples. Ooh, somebody's not muting their mic. Please mute your microphones, people. Right. So for those individuals that are having a hard time breathing, they're probably having complications with their respiratory system. So what happens is you're going to ask these additional questions, right? So for example, on page 335, weight gain. Is there any possible weight gain on that? Well, what does weight gain have to do with respiratory system? Well, fluids probably backed up from the heart and it went into the lungs, and then from the lung, or fluid from the heart backed up to the rest of the body, and then the fluids settle at the foot, right, causing pedal edema or fluids on the foot. So that causes weight gain because of problems breathing. Very common with patients with COPD or emphysema, which we'll learn more when we get into mod 4, right? So that's your respiratory system. I'll also like page 340 and 341 for my very visual learners of what it looks like in each of those systems. They gave a very good breakdown about the respiratory, the cardiovascular, the neurologic, the endocrine system, and the GI-GU system. Okay, so like I said, we're going to talk more about this when we get to mod 4, but we're introducing you to you early on. What are some possible tests that we can do specifically on our focus physical exam if your patient is complaining of a specific part of their body? So for example, I'm having a hard time breathing. Okay, I told you that. So on my chief complaint, you asked me my OPQRST. I told you it radiates on my jaw and my left arm. How are you gonna conduct a focused physical exam for your patient? 317. I'm gonna go ahead and mute you because you are causing some feedback. So please mute your microphones. This is your last warning. All right, so I'm going to ask that question again. So let's just say my chest is hurting, okay? And I told you it radiates on my left arm and my jaw. What type of focused physical exam? What systems are you going to inspect? Give me a general idea. Having a hard time breathing, left arm's hurting, and my neck and my jaw. Any ideas? So musculoskeletal, because checking their arms basically for decap ETLS, right, and the jaw. How about the chest pain, right? We're probably going to check their cardiovascular, right? We're going to inspect the chest. Maybe there's something wrong with their chest there, right? So those are some basic things that you can test out. Or if a patient is complaining of a headache or dizziness, right? There's probably signs of stroke. So on the neurological assessment, you might have to do a strokes test, which you're also going to learn when it comes to Mod 4. So for now, it's just basically introducing to you, these are all the systems of the body, and these are the tests that you're going to do. Okay, do you need to memorize them? No, but for now, we just want you to know, hey, you're going to need this again. You're going to need to refer back to this again when it comes to Mod 4. Is that clear, everybody? Okay, everybody clear on that one, right? So those are the different systems that you're going to probably have to tap into when it comes to a focused physical exam. Okay, right. Right. Any questions about the medical assessment of the general assessment techniques? Sorry, not the medical assessment, but the general assessment techniques. All right. And then we already talked about the difference between a responsive and unresponsive patient. I'm just going to refer to that table again on page 351. Again, this is the secondary assessment is done right after the primary assessment, right? You just have to determine, is my medical patient responsive or unresponsive? If they're responsive, then I'm going to go this way. If they're unresponsive, then I'm going to go this way. You don't have to do both of them. Does that make sense, everyone? Yep. Okay. Very good. So now let me go over the second part of your secondary assessment. Okay, let me do a quick screen share on here. Screen share, desktop, share screen, Mod 3 guides. All right, so secondary assessment, one last look. This is what it should look like, and it's also referred to on page 351, right? Responsive, unresponsive. Right, now let's look at the secondary assessment of a trauma patient. And notice I put an asterisk right there, as per textbook, right? I want to refer to textbook specifically for this because the mod tests refer to this specifically. So we're going to use that specific example right here, okay? So when it comes to your trauma patient, it's important to identify whether or not is it a non-significant MOI or is it a significant MOI. Non-significant MOI can be I sprained my ankle, I fell from a bike, and I'm still fine, right? So there's nothing too immediate that we have to address. Significant MOI are the things that we talked about on our scene size up. Falls, motor vehicle collisions, penetrating trauma, right, that's causing profuse bleeding. So those are your significant MOI. So let's talk about the non-significant MOI or the minor injuries. As per your textbook, you're going to start with HPI, history of present illness. So you're going to basically modify that to how did you get injured? That's basically a modified version of the HPI. Okay, well, are you hurting anywhere else, right? So you're kind of modifying your HPI for this non-significant MOI. And then you're going to do a focused physical exam because they're telling you, hey, I fell on my skateboard and my arm hurts. Obviously, there's no need to do a rapid trauma assessment because they're telling you, my arm hurts. I'm showing you right now, my arm is hurting. Okay, I know that, but let me do a quick head-to-toe exam. That is incorrect. If a patient is telling you that something is hurting, you want to do, and it's a non-significant MOI, you want to do a focused physical exam on that one. And then you're going to do baseline vital signs. Okay. Notice in your guidelines, if you're looking at the slides that I sent you, right after an exam or an assessment, vital signs always follows. So just please remember that exams, vital signs are always followed. Somebody is not muting their mic, and it's really, really annoying hearing that movement. So please mute your microphone. Okay, and then you're going to end with your past medical history, okay, if you're able to get it, right? HM1, why can I not ask my past medical history along with my HPI? Because the way that the book explained it is you don't want to, since this is a trauma patient, you want to spend your time of how they got injured, and then everything else like the history, like the past medical history, won't really affect, okay, how you're dealing with or treating your trauma patient. That's why the PMH is listed at the very bottom and not paired with the history of present illness. I just want to answer that now, just in case you are asking that in your head. And that's how the textbook explain it, and it does make sense. So that's for your non-significant MOI. But look at your significant MOI. It's the same thing. We're still going to HPI. So significant MOI doesn't always mean they're unresponsive, right? We're not doing unresponsive, responsive here. We're doing, is the MOI bad or is it okay? Well, the significant MOI is bad. So I'm going to try to get how they got injured by asking the patient or the bystanders or by looking at the scene. Okay, and then I'm going to do an RTA, a rapid trauma assessment. Notice, rapid. This means you got to do a quick head-to-toe exam. Okay, RTA, head-to-toe exam. And what did I say? Right after every physical exam and every assessment, you do your baseline vital signs. Okay? And then follow on with that, you're going to conduct a sample or an ample, which is your past medical history. And just like our unresponsive medical patients, you're going to conduct a detailed physical exam if you do have time and if every life-saving measures have been conducted. And this is preferably done when you're en route because detailed physical exams do take some time and your main goal is transport your patient right away. Okay, so that is the quick overview of your secondary assessment of a trauma patient. I'm going to stop the screen share. Okay, are there any questions about that? That help out a little bit? You guys have that little visual as a guide? Okay, right. So same thing with medical. Determine if your trauma patient is significant MOI or non-significant MOI, right? Because that will help you determine what type of exam is that. Question, what's the difference between focus and detailed? Focus physical exam is you're focusing on one body part. Detailed physical exam, I'm really taking my time on each body part from head to toe. I'm not just focusing on one body part, one or two several body parts. Focus physical exam can be, all right, my chest is hurting, my left arm's hurting, my jaw's hurting. Okay, good to go. Let me inspect your chest, your arm, your jaw. That's focus physical exam. Detailed physical exam means looking at every single crevice and detail of the body that I might have potentially missed on my focus physical exam or on my rapid trauma assessment or rapid physical exam. Does that answer your question? Okay, good to go. All right, so any questions with that overview class? Everybody good? Okay, like I said, you have the slides available for you. And the reason why I like showing that, because it gives you the type of assessments that you need to conduct, okay? If a patient fell on their bike, okay, and we can use the chat box on this one as well, and also for those of you that are using the mics. If your patient fell on a bike and they tell you, my arm's hurting, what type of exam are you gonna use? Focus, rapid physical, or rapid or RTA?
Focus.
Very good. You're going to do a focus physical exam, right? Focus physical exam because it's a non-significant MOI, and two, your patient is already telling you, my arm's hurting. Let me give you another example. Patient had a heart attack. Patient passed out and slipped on the tub, okay? So they're now unresponsive when you got there. What type of exam are you going to use?
Significant. Trauma.
Rapid trauma, RTA. Okay, very good. So rapid trauma assessment, since they slipped on the tub. Don't let the heart attack confuse you. The heart attack is medical. Well, rapid trauma, remember, rapid trauma assessment and rapid physical exams, exactly the same. We just call it different because the RPE is for more of medical, RTA is more of trauma. So don't freak out of those two terms right there. Just be careful of how you're using it when you're presenting it to the skills, okay? All right, so in your... excuse me, in your trauma assessment, we introduce several acronyms on there. We have DCAP, BTLS, right? You guys know that? HM1, I was asleep when that lecture was taught. So page 367, everybody go to that, flip over that page, 367. That's where you're going to find DCAP, BTLS. DCAP, BTLS stands for deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. Right? DCAP BTLS. If your DCAP BTLS, okay, if it's too long for you, an alternative is WTD, wound tenderness deformities. And I already know 98% of the class is going to be like, oh, I'm definitely going to use WTD. That is 3 letters and it's easy to remember. However, comma, pause for effect. DCAP BTLS and WTD needs to be known for testing purposes. I'm just putting it out there, right? Skills purposes, you have the options of DCAP, ETLS, and WTD. But you gotta know, okay, for mods 3, 4, 5, and 6, they might randomly throw out because the decap BTLS will keep showing up, okay, specifically a mod 5. All right, so I want to make sure that you guys know that now for decap BTLS and WTD, right? Because they found out, well, you know what, decap BTLS is too long. Let's generalize it to WTD, okay? Then we also get a lot of questions from our students. HM1, how do I know what to look for when it comes to a rapid trauma assessment or a rapid physical exam for my patient? The book gave several things on there, and I'm just like really confused. Well, for those of you that are looking at your emails, I want you to go back to that email, and I created a table. Okay, this table will be your best friend for an RTE, or for an RTA or RPE. Okay, so let me do a share screen real quick. Okay, so that's your secondary patient assessment. Again, so this is for your RTE or RPE. So if you're looking at the screen, okay, it says right, the left side, okay, has all your body parts. It starts with, hey, do you want to use WTD or decap BTLS? If so, you're going to use that in combination with everything else that's on here. HM1, oh my God, do I have to memorize this now? No. Calm down. Don't shit yourself. Don't throw up. I'm just introducing to you what you're going to potentially look. However, we're the only class who introduces these concepts early on. That's why you guys do so well in 4 and 5. So if I'm looking at the scalp, I'm going to use decap BTLS plus crepitation. HM1, what's crepitation? That's the rubbing of the bones, right? That's the crushing of the bones that you're hearing. For the eyes, you're going to use the acronym BADFIR. BADFIR stands for blood in the interior chamber, discoloration, any foreign objects, unequal pupils, raccoon eyes. HM1, I don't know what anterior chamber is. That's basically those bloodshot eyes. So if I punch you in your eye and blood starts forming up, that's blood in the anterior chamber. Raccoon eyes are basically, what does a raccoon look like? They have like a black eye underneath. That's a sign of a head trauma. So BADFIR is the easiest way to remember that. For the ears and nose, we look for the same thing. Decap BTLS plus CSF, that's cerebral spinal fluid, and blood. If there's blood and CSF leaking out of the ears and nose, okay, that's something that we need to annotate. For the face, decap BTLS and crepitation, because your face does have a lot of bones, right? And then for your neck, decap BTLS plus JVD, that's the jugular vein distension. That's when the veins of your neck are popping up. So when HM1's yelling at you and you look at my neck, those veins are popping up. That's an example or a JVD. Tracheal deviation is a late sign to where you're going to learn in Mod 5 about what we call pneumothorax. When the lungs has a lot of pressure, it causes the trachea to shift. Stoma is a surgical opening on the neck. Oh, I made a mistake on this one. This is C1 through C7. Sorry, I'll edit your PowerPoints for this one to reflect. I accidentally hit Shift. C1 through C7 because you have 7 bones on your cervical spine. And notice I put an asterisk. This is also the time that you're going to put on a C-collar. You're going to learn in Mod 5 how to put on a proper C-collar. Okay? Then you're going to assess the chest. Okay? For the chest, you're going to look for paradoxical motion. Paradoxical motion happens when there is a flail chest, okay? Flail chest is basically means that there's 2 or more ribs that are broken that's causing your chest to not rise equally. So that is your paradoxical motion. You're also going to look for entry and exit wounds because, hey, bullets might be hiding underneath. And you're going to auscultate mid-clavicular bilaterally and mid-axillary bilaterally. And we'll also show you this once it's time to show you how to properly assess your patients. Then you have your abdominal area. For your abdominal area, you're going to have the acronym TURD-P. You're going to look for tenderness. Evisceration. Evisceration means guts hanging out of the patient. Rigidity and pulsating mass. Okay, so pulsating mass means something's like throbbing of the abdominal area. That's a bad sign because that's probably the aorta about to pop. And then on the pelvis, okay, you're going to push in and down looking for a facial grimace. That's basically meaning that if you push on the pelvis and they're like squirming a little bit, that's probably a sign that the pelvis is broken. And if there's crepitation or crepitus on there, it's probably a sign that there's spinal damage. And what's around the pelvis? A lot of arteries, the iliac artery, the femoral artery. So if you move around your patient a lot, then that's possible danger right there. Then you have the genitalia. For the males, you're going to check for priapism. Priapism is a persistent erection, not just an erection, a persistent erection, indicating spinal damage. And then for the females, it's excessive vaginal bleeding, okay? And you're going to look for a vaginal trauma or crowning. H1, what's crowning? That's when the head or any part of the baby is starting to show up, right? Because that can happen too. A pregnant lady gets into a car accident and the head of the baby showing up, that's a sign that it's time for delivery. We'll talk more about that in Mod 6. And then lower extremities, basically your legs. You're going to check for CSMs bilaterally. CSM stands for circulation, sensory, motor. You're going to check for the pulses. You're going to ask your patient, sir, can you feel this on your feet? Can you wiggle your toes? This will basically allow to give me an idea whether or not there is a spinal damage, okay? And then for your upper extremities, you do the same thing. CSMs, check for pulses bilaterally. Sir, can you feel this on your fingers? Sir, can you wiggle your fingers? This, again, will tell me if there's any damage to the spine, if they are able to, or not able to feel or wiggle anything. And last but not the least, you're going to check the posterior side, basically the back of your patient. You want to inspect the spine, the lumbar area, and the buttocks for any urine or feces, because if the patient got into a car accident and they're sitting on a pile of urine or feces, that's probably a sign of spinal damage. And this is also the time that you're going to put them in a long spine board, and that's how you're going to do the rapid trauma assessment and a rapid physical exam, okay? Right. So like I said, there's no need to memorize all those right now, but I want you to be familiar. Okay, be very familiar with those terms that I just mentioned. Priapism, paradoxical motion, all those terms are listed on here on this specific chapter. Okay. Somebody is not muting their mics. Please, you are being heard by everybody who's on the video. Mute your microphones. So whoever's using the iPhone, you're the one who's ringing. You have no name. You need to mute your microphone. All right. So any questions with the RTA and the RPE? Because that basically covers what I wanted to cover on those little sections here and there with the rapid physical exam and the rapid trauma assessment. Any questions with those, class? And I also provided this to you via PowerPoint, so you have this at your disposal. You had a question? What is the question?
I just observed that in that CERDP, the delta didn't have a word on it.
Oh, I'm sorry. It stands for distension. Okay, and I'll update that. Sorry, it was just a rough draft. I typed it up before I sent it to y'all guys. That's why in the subject line I put rough draft. So I'll make the corrections and I'll send out a new one for you guys.
Thank you, Rachel.
Yeah, no problem. Right, so any questions at all about the DCAP, BTLS, or anything that we're supposed to look for on the body when it comes to a rapid trauma assessment? Because we're almost done here. We're at the tail end of our review. Right, everybody good now, right?
H1?
Yes.
H1. So tomorrow, we don't have to know the WTD part, just the DCAP, BTLS?
I need you to know both. I need you to know WTD, DCAP, BTLS, right? I need you to know those basic concepts. What I don't need you to do is like start freaking out and stressing and memorizing that table that I provide you guys via email. It's just basically preparing you what to do. It's WTD, not WTE. W Whiskey Tango Delta.
Yeah, WTD. Yes, sir.
Yep.
Yes, H1. All right.
Okay. All right, and that is for your trauma patients, right? And your book gave you pictures. That's the whole reason why it looks like it was a little long. WTD, wounds, tenderness, deformities, as we've discussed. Wounds, tenderness, and deformities. All right. Any questions at all with secondary assessment? All right, so let's move on to the detailed physical exam, page 388. The only thing that I have to say about this, you're only going to do a detailed physical exam if you have time. If you have time. This does not take precedence over primary assessment, over secondary assessment. over reassessment. Detailed physical exam is only done en route, and if you have time. A lot of students get so focused, oh, I got to do a detailed physical exam of my patient. Only if time permits, okay? Only if you can do that, because if you are still BVMing your patient, hey, I'm not going to be able to do a detailed physical exam because the BVM takes priority over a detailed physical exam. Okay, does that make sense, everyone?
Yes.
Okay, this is my last screen share for you guys about the reassessment, right? So I'm going to do the screen share. This is the last portion of your patient assessment. So if you look at the slide, I arranged it from scene size up all the way up to reassessment, and those are your key components. So if I give you a part of a patient assessment and you can tell me, oh, that's at scene size up, oh, that's at a secondary, oh, that's at reassessment, I'm going to be the happiest HM1 alive, right? Because that tells me that you understand the flow of the patient assessment process, right? So let me do a screen share here real quick. Share. 1, 3 guys. There we go. Right, reassessment. Reassessment can be summarized into 4 letters. I love mnemonics because it helps it out. The mnemonics for reassessment is VIPS, V-I-P-S, stands for Vitals, Interventions, Primary Assessment, Secondary Assessment. This is just a mnemonic, okay? Don't think that you have to do vital signs first. It's the primary and the secondary assessment that you have to do first. And then you're going to reassess the primary and secondary assessment. So basically, you're going to recheck the ABCs again. For the secondary, you're going to redo a physical exam just in case to make sure that the patient's not feeling any different, right? For the vital signs, you're going to reassess every 5 minutes if they're stable, every 15 minutes if they're, every 5 minutes if they're unstable, every 15 minutes if they're stable. And then you're going to do your interventions, okay? Interventions are the medications that we're about to give our patients. And it's simply asking, hey, ma'am, are you feeling any better, right? And it's checking those oxygen that we place on our patient as well. So that's the reassessment. And like I said, you have this on your emails. And I'll create a prettier one on this one as we go through because this is not the last time that you're going to see this. If you think that you're only going to see this for Mod 3, you are wrong. Okay, so that is for your reassessment part of your patient assessment. Any questions with that one, class? Okay, so again, reassessment, VIPS, vitals, interventions, primary, repeat primary, and secondary assessment, right? Okay, so any questions with the reassessment part? Okay, so everybody flip your books to page 393 real quick. I want to show the very important concept that students tend to forget. 393. Look, everybody look at the top portion right there. The one that's italicized. It says right there. Reassessment, however, must never be skipped. Okay, so we never skip reassessment except when life-saving interventions prevent you from doing it. Question 1, what are examples of life-saving measures? Let me give you an example. When you're BVMing a patient, that's a life-saving measure. Bag valving them, I'm not going to stop it like, oh, it's time for reassessment. Let me put down the BVM. No, they need that. That's part of the ABC, right? If a patient is still bleeding out, right, and you haven't controlled the bleeding, you're not going to let go of the bleeding. It's like, hey, it's time for reassessment. No. In real life, you can be stuck in a primary assessment for a long time, right? Or you can be going back and forth with primary, secondary, primary, secondary. Reassessment might never even happen if you haven't addressed the life-threatening issue. The purpose of a secondary assessment is to identify the life-threatening injuries that you might have potentially missed, okay, in the primary assessment. And the reassessment basically rechecks everything that you provide, the treatments that you provided during your primary and your secondary assessment. Okay, does that make sense, class? Okay, thumbs up, everybody good? Okay, perfect. Okay, so that's for your reassessment. Like I said, simply summarized by the letters VIPS, vitals, interventions, primary, and secondary. Okay. On page 396, if you want to challenge yourself, it's a good exercise just to look if you know for a fact, if just by looking at this, you can tell if your patient is improving or declining, that means you have knowledge of your vital signs already. So remember, I told you look at your emergency student packet guides, at least the adult portion. I want you to know the adult respiration, adult pulse, adult BP. Okay, those are the three main ones that at least I want you to know, so that when you're giving a scenario, you know how to identify whether they're doing good or they're doing bad. Okay, any questions for that, class? All right, last section of the chapter 14, critical thinking and decision making. We do not diagnose as an EMT. However, we come up with field diagnosis or field impression. So these are the things that are what we think possibly is happening to our patient, right? So this can range from possible altered mental status, possible cardiac emergency, possible allergic reaction. So we never say for definite, oh, this is the allergic reaction. No, we always start with possible, right? Because I'm not a doctor, we're EMTs, so we leave it up to the doctors on who diagnoses and who confirms those diagnoses. So to summarize this last section right here, I want you all to go to page 404. Okay, look at page 404 on table 14, tech 10 right there. That is the summary of that chapter. It's basically differentiating what happens, what we do, okay, as an EMT compared to an emergency room doctor compared to a regular doctor. That's their difference right there, okay? So for those of you that have access to chat box or those that have audio, based on pace, okay, based on pace, which one or which individual conducts a very urgent, okay, type of assessment? Is it the EMT? Is it the emergency doctor? Or is it the regular physician? Very good. It's the EMS approach. It's the EMT. We have urgent. The doctor, they take their time. So how you doing today? Oh, cool. How's your dog? How's your cat? We don't have time for that in the EMT setting, right? So traditional physician approach and EMT approach, quite different, right? Another thing that we do have, resources, okay? Emergency room doctors and EMTs have limited resources. Physicians have unlimited resources. They have every access to everything, right? That's what physicians have. But as EMTs, we only have what we have in the back of our ambulance, right? So again, table 14, tech 10, it's a quick summary and a quick picture. What's the difference between a regular doctor, an ER doctor, and an EMT? Does that make sense, class? Right? So if you're going to review something on that specific mid-chapter, look at that table, and I promise you, I'll give you that clarification right there. Okay? So any questions at all with chapter 14? Because I'm just going to breeze through 15 here real quick, and I will let you go on your way. Any question at all with 14? I know it's a pretty long one. I tried my best to break it down for you as much as I can using those PowerPoint slides and explaining it to you as well. But are there any questions? All right. Looks like there's no questions. Let's end our review with chapter 15, communication and documentation. So know the difference between base station, mobile radio, portable radio, and repeaters. Base station, fixed facilities, right? Mobile radio, somebody from Alpha said something smart came up with it, automobile, right? So it's in a vehicle. Portable radio is the one that we hold on to. Repeater is just basically a booster, a signal device booster, right? So those are the main differences for that one. The agency that looks over all this is the FCC, the Federal Communications Commission, FCC, okay, FCC. And then page 415, table 15, tech 1, right? Make sure that you're talking 2 to 3 inches away from the microphone or the radio. Okay, you wait 1 second for the push to talk. There's no need to say please or thank you. It's already assumed. Don't use codes. Don't use slangs. Say affirmative and negative instead of yes or no. Speak slowly and clearly so people can understand you when you're over the radio. Okay. So also there's no need to use the words please, thank you, and be advised because it's already assumed that you're utilizing that one. Okay, so those are like some basic radio etiquette. And then we have the radiomedical reports. There's 12 parts to the radiomedical reports. Notice nothing on there says patient name. Nothing on there says patient name. Okay, so when you're giving a radiomedical report, okay, you do not need to give a patient name. Okay, it's only the unit identification level provider, ETA, patient's age and sex, chief complaint, HPI, PMH, mental status, baseline vital signs, anything that you found in the physical exam, emergency medical care given, what was the response to it, and medical direction contact. Okay, any questions with that? Again, no patient name on radiomedical reports. Okay. Then we have the verbal report. I taught this to Alpha, but I'm going to let Bravo know as well. Your book only gave you 4 parts to the verbal report, but there's actually 9 parts to the verbal report. So write this down if you haven't done so. 9 parts to the verbal report. Number 1, age and sex. Age and sex, verbal report. We're on page 418. Okay. Age and sex. So I would write it on the side of your margin of your book. Number 2, chief complaint. Number 3, level of consciousness. Number 4 is your HPI. Number 5 is your PMH. Number 6 is your focus physical exam, or your physical exam findings. Number 7 are your vital signs, both baseline and reassessment vital signs. Number 8, interventions. And number 9, response. So those are the 9 components of your verbal report. You miss one of those in skills, they automatically failure for it. So we're introducing it to you early on that there are 9 components to the verbal report. Okay? So any questions for that?
HM1, what was the first 4?
The first one is age and sex. Okay. Any questions for that at all, class?
Can you name the next 3?
Oh, you basically want me to repeat everything all over again because you failed to listen.
No, just until 5 or PMH. I got PMH and everything after that.
Okay, I'll repeat it. Number 1, age and sex. Number 2, chief complaint. Number 3, level of consciousness. Number 4, history of present illness, or your HPI. 5 is past medical history. 6 is any physical exam findings. 7 is your vital signs. 8 are the interventions, and 9 the response to the interventions. Make sense?
Yes, thank you.
Yep, no problem. Right, so some basic rules when you're talking to your patients. Eye contact when needed. Okay, be aware of your body language, because body language is everything as well, right? Be honest with your patient, use simple language, and listen to your patient and use their proper name, okay? So those are very basic, straight to the point, and direct instructions on how to talk to your patient. Pediatric note, talk to your patient on an eye level, okay? Eye level. You don't want to tower to your patient, so you might have to kneel down when you're talking to your child, okay? Right, last one, last portion. Okay, pre-hospital care report. Pre-hospital care report. Pre-hospital care report or drop care report is a legal document. It basically contains everything that you need to have when you're transporting your patient to the ER or the emergency room. Okay, so the things that the pre-hospital care report are used for. Number 1, page 424. It's a patient care record, right? Everything that you've given your patient, it's contained on there in that pre-hospital care report. 2, it's a legal document, okay? It's a legal document and it can protect you in case your patient tries to sue you. Okay, 3, it's gonna be, it's for administrative purposes, for billing, for insurance. It's some pre-hospital care reports contain that. 4 and 5, educational research and quality improvement. That's on page 426. That's what we can use pre-hospital care report for, because it tells you how long you've been with the patient. So if I want to tell you, hey, EMT Jones, you've been spending 45 minutes on this call, we might want to reduce it to about 30. So let's see what we can do. Let's look at your past 16 pre-hospital care reports, okay? Because your medical direction does get that one as well, okay? the last two things that I do want to talk to you about is the subjective and objective things that are listed on there. So subjective is basically things that your patient tells you. Okay. Objective is things that you see and you can measure. Okay, so vital signs are example of objective things that you write down. Subjective is a patient says, I feel nauseous. I feel like an elephant is sitting on my chest. Those are all subjective. Okay, so because we can't measure them. Remember, if you don't write it down, never happened. So make sure that you do write it down when it comes to pre-hospital care report. Okay, and then the last thing on here is special documentation. So we have confidentiality. Your patient is protected by the law called HIPAA, okay? Health Insurance Portability and Accountability Act, that is HIPAA, okay? And basically, everybody who is involved in the patient care process are the only individuals that needs to know what's going on with your patient. So just like that question on my brain about the security guard doesn't need or will not get a copy of the pre-hospital care report because he's not part of the patient care process as per the HIPAA. Okay. Patient refusals also needs to be documented there. You have to try to convince your patient, write down everything that you did in order to convince the patient, and then have them sign the release form and have a witness sign that release form as well. Okay. When you make errors in your pre-hospital care report, you want to make sure that you one line and you initial it, just like what we do on our logbooks as well, okay? And that's basically the last thing that I do want to talk to y'all about for that specific chapter, okay? Are there any questions, comments, or concerns at all about chapter 15? Like I said, it's a very short one, and I just want to easily breeze through it, okay? We successfully covered all 5 chapters in 2 hours. So hopefully you guys helped out a little bit for y'all. Are there any questions?